Hello, everybody. Welcome to Ophthalmology Mastery Clinical Skills for MBBS students. So, in this presentation, we'll learn about xerophthalmia or vitamin A deficiency. So, what is xerophthalmia? These are the ocular manifestations of vitamin A deficiency. So one, you will have two things that happen in vitamin A deficiency. Basically, vitamin A is important for the epithelial health of the cornea and conjunctiva, and also the functioning of the rods and cones. So vitamin A deficiency, you will see structural changes of conjunctiva and cornea, and also you see biophysical disorders of the rods, basically the rods. So structural change of the cornea and the conjunctiva will manifest as goblet cell deficiency, which can manifest as epithelial xerosis. Biophysical disorder of rods will manifest as deficiency of rhodopsin, which can lead to night blindness. So you'll have symptoms of both epithelial xerosis and night blindness, and these are the main symptoms of any patient with vitamin A deficiency. So WHO classifies vitamin A deficiency as X stands for xerophthalmia and N is night blindness. So it classifies as XN, X1A, X1B, X2, X3A, X3B, XF and XS. So what is X? What are all these? XN is night blindness. N stands for night blindness. So where the patient presents with night blindness, he'll not have any other symptoms. Okay, X1 is conjunctival involvement. X1A is conjunctival xerosis, where you'll see drying of the conjunctiva. The normally moist, wet conjunctiva looks very dry. X1B is bitot spots, where you'll see a whitish triangular lesion with apex away from the limbus, which has a frothy white appearance on the conjunctiva, and this is very typical of conjunctival xerosis. Sorry, bitot spot. X2 is corneal xerosis, where the normal sheen of the cornea is lost and the cornea looks lusterless and dry. X3A, 3x3 is corneal ulcer. X3A is when the corneal ulcer, corneal melting is less than 1/3. X3B is when the corneal ulcer is more than 1/3 of the corneal surface. So basically, it's an initially to begin with, it is a non-infective melting of the cornea, non-infective ulcer, but later it can get infected and present as a bacterial or a fungal corneal ulcer. XF is a xerophthalmic fundus, where we see salt and pepper fundus findings, and XS is xerophthalmic scarring of the cornea, where it has already gone through the corneal ulcer stage and it has healed and leading to scarring of the cornea. So all these, beyond this, if the corneal involvement is there, the vision can reduce, and usually vitamin A deficiency affects children, and this results in corneal blindness in children. So it's very important to identify vitamin A deficiency, treat it, and also prevent it. Now, how do you treat vitamin A deficiency? We have to do two things. When we see vitamin A deficiency, we see xerophthalmic xerophthalmic findings. One is local therapy and second is systemic therapy. Local therapy is one when you see for dryness, and second is for corneal ulcer. When you see xerosis, whether it's a conjunctival xerosis or a corneal xerosis, you have to give them artificial tears. When you see keratomalacia, such as corneal ulcer, okay, you have to treat it like a corneal ulcer, where you will treat with, like any bacterial corneal ulcer, you will treat with antibiotics because there's an epithelial defect. You will treat with cycloplegics, and if it is a very large ulcer, it is perforated, there's an impending perforation or it's already perforated, you will go ahead and do a surgical keratoplasty. Vitamin A deficiency, when you find findings of vitamin A deficiency, just local therapy is not enough. You have to do systemic therapy, where you will treat every stage from XN to X3B. You will treat with vitamin A supplementation. Okay, vitamin A supplementation can either be as a treatment or prophylaxis. Treatment is when you identify xerophthalmic features, you have to treat it. But there is also a dosage for prophylaxis that will go later. How do you treat? This is the treatment dosage for all patients over 1 year of age. The treatment protocol is day 1 200,000 international units or 2 lakh international units orally or 1 lakh international units IM. You will repeat the same dose next day and 4 weeks later. Okay. It's very important the 3 doses are given for the patient, not just one dose. If children are less than 1 year of age or less than 8 kg, the treatment is halved. Okay, so instead of 2 lakh, you'll give 1 lakh international units orally or 50,000 international units IM on day 1, day 2 and 4 weeks. So remember, if it is a child less than 1 year or less than 8 kgs, you'll halve the dose. Okay. Pregnant women from XN to X1A and X1B. So if it's only conjunctival involvement and night blindness, the treatment is 10,000 international units for 2 weeks, every day for 2 weeks. But if it is X2 and above, when there's corneal involvement already, then there's a high risk of this one to progress, corneal involvement to progress, and high risk of the women going blind. So you have to do a full treatment like any other individual. 200,000 international units orally, day 1, day 2 and 4 weeks later. Okay. Prophlaxis, that is the treatment where you will do local treatment and vitamin A treatment. Prophylaxis against vitamin A deficiency, the government has identified short-term approach, medium-term approach and long-term approach. So each one is done to prevent vitamin A deficiency in the community. So the short-term approach is if it is less than 6 months and if the baby is not breastfed. If they're breastfed, usually they get derived the vitamin A from the mother's milk. So if they're not breastfed, then 50,000 international units is given as a drop, oral drops. Between 6 to 12 months, 10 lakh or 1 lakh international units for between 3 to 6 months, every 3 to 6 months. Greater than 1 year and less than 6 years, okay, every 6 months 2 lakh international units are given as oral drops. For lactating mothers, you will give 20,000 international units once at delivery or within 2 months. This is the short term approach to prevent vitamin A deficiency in childhood and to prevent corneal blindness happening due to vitamin A deficiency. What is the medium term approach? Medium term approach is to fortification of food with vitamin A. So either with salt, the oil, cooking oil, or milk, or even the atta, the wheat, that can also be fortified with vitamin A. This is the approach that the government has adopted to prevent vitamin A deficiency and corneal blindness due to that. The long term approach involves promotion of adequate intake of vitamin A rich food at the periphery, at the PHC level, where patients and communities are educated to eat food rich in vitamin A, such as green leafy vegetables. Carrots are probably are more costly to be uh, procured at village levels, but green leafy vegetables are very easy to get, and so you have to promote adequate intake of vitamin A rich food, and nutritional health education is also very important as a long term approach.